Hello, everyone. Welcome back to another Friday. Today we are missing 1 hour. Rob is not be able to be here. I think he's traveling back from his vacation, but we have Professor Reza that, we still love to work. And we have a case presenter, Erin. She's from Baylor. Erin, do you want to say hello for us?
Yeah. Hey guys, I'm PGY2, almost PGY3 at Baylor Internal Medicine. I'm applying for infectious diseases this year.
You know, the
Uh,
important thing, Deborah, when they tell you what specialty they're interested in, you almost want to prioritize that bucket of disease when you're discussing the case. But if you do that, oftentimes those individuals tend to have interest in other areas, especially ID. So now my mind is a bit puzzled and bewildered as to what to expect.
yeah, I love all medicine, so you're absolutely right there. Okay, should I go ahead and get started with the case or? Okay. All right, so we have chief concern. We have an 84-year-old man, and he's coming in with 2 days of upper abdominal pain. So he's 84. His only medical history is high blood pressure, prediabetes, and BPH. He's coming in because he woke up 2 days ago with this sharp, kind of achy upper abdominal pain. He was in his usual state of health until that point. When he first woke up 2 days ago and had the pain, it was about a 2 out of 10. And he said it was sharp, kind of intermittent. It was worse when he ate his meals, but it was also there when he wasn't eating. And then in the last 2 days, it's progressed to a 10 out of 10 pain. So much so that in the last 24 hours, he has not eaten anything at all. Um, he has never actually vomited, but he has had nausea and a lot of discomfort, which is why he hasn't been eating. He tried to take some Tylenol and take some Tums, but they didn't help. Um, he has been trying to drink a lot of water as well, but kind of always feels like he's dehydrated. Um, and just for some more context, he hasn't been to the doctor's office in about 5 years. But these diagnoses that he carries, the high blood pressure, prediabetes, he's had those for like decades. And he's been on the same medications um, and hasn't seen a doctor, and he's been fine until this point. He has 4 grandkids and 2 dogs, and he's usually very active, fully functional in his ADLs and IADLs, hangs out with his grandkids a lot. But over the last 2 days has been so tired and uncomfortable that he has not been able to do that and hasn't been able to walk the dogs. And everyone in his family is very concerned because this is very out of character for him. Review of systems, he has just generalized weakness and malaise, and he says he might feel hot. He's never taken his temperature, but he feels kind of hot, so maybe some subjective fevers. And negative pertinent review systems, he doesn't have headaches, no syncopes, no chest pain, no shortness of breath, no diarrhea or constipation, no dysuria, no hematuria, no hematochezia or melena. So I'll stop there for the first aliquot.
Wow. What a well-constructed first aliquot of information, Aaron. And I just realized you're going to be a second year for just a few more days, right?
Yeah,
Soon,
3 more days.
soon you're going to introduce yourself as Aaron PGY3 and soon to be ID fellow.
Oh, no, no. So I'm a PGY2 and soon to be a PGY3.
Exactly, yes.
Yes.
Um, I think this is such a rich aliquot of information. And I think the mistake to do here as an audience member is try to arrive at a diagnosis because we really don't have a clear problem yet or a pivot point. So I'm going to share authentically with you what I would be thinking about in real life and just keep it very fundamental. If I'm in the ED and I see on that electronic board that there's abdominal pain, I quickly start activating my schema for abdominal pain. And I will say abdominal pain is probably one of the top 3 chief concerns that patients present to the emergency department with. So you're going to see so much abdominal pain in your training, and you're going to develop a framework, an approach. And then as you gain more and more experiences, you're going to be able to take out nuances and prioritize specific diagnoses. With this individual, before I even take into account their past medical history, with abdominal pain, I quickly run a few possibilities that are life-threatening, especially if it's intense abdominal pain. Now, if this was just a 2 out of 10 intensity and I saw him then, I wouldn't be running the list of very, life-threatening causes of abdominal pain. But once you get to 10 out of 10 and it's affecting your daily living, you should have that list, just like you have it for chest pain, just like you have it for jaundice, just like you have it for the red eye. And for abdominal pain, my list, and your list may be different, includes obstruction, and obstruction not only of the intestines, but obstruction of a vessel, like a coronary vessel. So you look at his past medical history, you see hypertension, diabetes. Could he have CAD? Could this be a complication of atherosclerosis, whether it is acute coronary syndrome or a dissection? So perforation, obstruction, and another very important cause, and this is it's exclusively in women, would be ectopic pregnancy. So I go through that list in my mind, not to say that I send tests to evaluate each of those, but for instance, right away, I'm going to be sending an EKG, I'm going to be sending a troponin, because I know abdominal pain can be a presenting symptom of referral pain from the coronary vessels. Once I go through that list, then I think about the quadrants, and the quadrants are helpful, but you have to be cautious there because the organs are so packed closely together that you can have problems with the spleen, but that can manifest as epigastric, an organ that's located in the left upper quadrant. You can have problems with the liver, organ in the right upper quadrant, and that can, present as epigastric pain. This is upper abdominal pain, so I'm going to be prioritizing organs in the epigastric region, and that includes the stomach, so gastritis, GERD, or and peptic ulcer disease. All of these can cause, epigastric abdominal pain, and actually, someone can have an peptic ulcer disease that then perforates. So maybe initially he had some peptic ulcer disease, he ate food, the pain worsened, and now he has a complication of that via perforation. I'm just showing you how you can synthesize a story that makes sense for this patient. There are a few causes of abdominal pain that can happen anywhere within the abdomen. And that includes stuff like constipation, colitis, and another really important cause of sort of upper abdominal pain in an elderly with diabetes and hypertension is just thinking of the aorta, which you can have an aneurysm, you can have a dissection. Then I try to take away subtleties from the presentation. The pain is always there, but it's worse with eating. Pain that's worse with eating, all you have to do is imagine where the food or water travels through. So if someone has gastroparesis, peptic ulcer disease, pyloric stricture, biliary pathology, all of that can lead to pain with eating, even if they have mesenteric atherosclerosis, they can develop angina. But I'm not putting too much weight on that. I'm really not, because the pain is always there, and it's just some ideas that come to mind. The nausea without vomiting, I think that you still have to be concerned for large bowel obstruction. Oftentimes, they don't have as much nausea and vomiting, but that's another cause of abdominal pain. So where would I go from here? So what you're seeing is I'm struggling to really have a narrow DDX. And it's not just because Robbie isn't here. It's because the case at this juncture is quite non-specific. The patient has potentially subject to fevers. We'll see if on exam we actually document a fever. So in summary, with abdominal pain, think about the life-threatening causes from obstruction to perforation to ischemia. Then take a quadrant-based approach with caution, knowing that the organs are so closely packed, and prioritize those organs that are located in the region of the abdominal pain. Then use other clues like worse with eating or associated with nausea to even try to make more progress on refining that frame, that problem representation, to then prioritize etiologies like peptic ulcer disease. But at this juncture, we need to make sure we're not dealing with acute coronary syndrome, a dissection, or something life-threatening. So why don't we move along the case? We'll get the physical exam, and we'll see if that adds any further clarity, but we do not have a pivot point yet.
Awesome. Amazing discussion. Okay, so I'll just keep going with kind of a rounding out the past medical history, family history. So he doesn't have anything else besides what I mentioned already, high blood pressure, BPH, and type 2 diabetes. Has never had any surgeries. Social history-wise, he's a never smoker. He drinks maybe 1 to 2 beers per week, has never, abused alcohol or any other substances. He was born in Mexico, but he came here in his 20s, and he's lived in Houston for the last 60 years. No recent travel and no occupational exposures. He worked like a desk job his whole life. He has 4 grandchildren and 2 dogs, as I mentioned. They're indoor dogs, and none of his grandkids have been sick recently. And he has no allergies.
Aaron, that's how we know you're ID bound, like specifying indoor. I wouldn't even know to ask that question. I thought all dogs are indoor dogs, but that's awesome.
Okay, and so moving on to the vitals and exams. So his temperature was 99.6. Heart rate was 112. Blood pressure initially in the ambulance was 80s over 50s, which improved to 110s over 70s after 3 liters of fluids. He's breathing about 20 times a minute and saturating 97% on room air. His BMI is around 30. And generally, he's lying in bed. By the time I see him, he is pretty comfortable, but he received some morphine. He does have some scleral icterus. He has on cardiovascular exam, he has a fast rate, but a regular rhythm. And he has some jugular venous distension on the right side. I didn't measure exactly how much, but it was distended. Pulmonary exam, he has some mild bilateral crackles in the posterior lung fields. And abdominal exam, he does have some, at this point, mild epigastric tenderness. Again, he had received morphine already, but no hepatomegaly or splenomegaly that are appreciated, and no CVA tenderness. On his extremities, he has 1+ pitting edema to the knees. And neurologically, he's intact. He's very pleasant, and no deficits. Go ahead and stop there.
Awesome. Again, thank you so much for such an amazing job presenting this case and giving all the data that I need to confidently discuss it. And I want to applaud you, Aaron, actually. Like, I think the idea that we have to be able to say JVPs at 10, at 11, I would actually argue that no one can accurately measure the JVP. 99% of us can. So I would encourage you, rather than try to make it complicated, do exactly what Aaron did. Is it distended or not? That's it. And is it improving or not day to day? That's literally how I practice, and yeah, I just think that's the way to do it. So thank you for that. So now we have this elderly individual with a history of diabetes who's presenting with maximum pain in the epigastric region and has striking vital sign abnormalities. So out of all this data at time point 0, which would be the one I exclusively focus on before I start thinking about the other data is the blood pressure. Because if the blood pressure is low, you won't be perfusing your organs. And this individual, in high likelihood, is in shock. In order to be in shock, you actually have to have evidence of end organ hypoperfusion, which manifests in the form of lactate elevation, creatinine elevation, and really ends like very low blood pressure could lead to confusion and lethargy and such. So now you gotta put the abdominal pain aside for a second and just be like, okay, hypotension. How do I approach that? What are the tests going to be that I'm going to send? And what are going to be my initial management steps? So we're going to take a break from diagnosis, go straight to management. But these two domains are always interlinked. You can't do one without the other. With hypotension, and I'm sure Erin is reflexive in her approach, and many of you will be throughout your residency. But you have to ask the question, are you dealing with a hypovolemic, an obstructive, a cardiogenic, or distributive cause? Those 4 buckets. And when you're going to this patient's bedside, although EMS is going to be doing a lot of this early on, you just tell that bedside nurse, start fluids wide open, recheck the blood pressure, and you go to the bedside. And if you elevate the legs, that in itself would be a bolus, and you'll see if they're volume responsive. And you may say, wait, what about if they have cardiogenic shock? Should we be giving fluid? Anyone who's hypotensive, initially give fluid. Then you may have to do other stuff like pressors or inotropes or even intubate to support that. But let's see if we can make any more progress diagnostically with the HPI, the rest of the exam, into which bucket we're located in. All you can do when you go to the bedside to try to make progress is you can touch the skin. If it's warm, if the pulse pressure is wide, but the pulse pressure, it's not usually that helpful when the blood pressure is this low. That can point you towards distributive. So this patient's temperature is 99.6. Their age is 84. Their marrow is primarily replaced with fat cells, so they're not going to be able to mount an immune response. So you absolutely have to include distributive shock, specifically from an infection on the DDX. But then you look at the JVP and the JVP is elevated. The JVP being elevated, now all of a sudden you have to ask, could they be in cardiogenic shock or obstructive shock? Because remember, when you have a JVP that's elevated, all that's telling us is that the pressures in the right atrium are up. Now, those pressures can be up from a pulmonary source like PE, from a pericardial source like tamponade, or they can be up from ACS. That's really the narrow and prioritized DDX. So now I'm worried about both obstructive and cardiogenic. Then you go and you say, wait a minute, this patient also has scleral icterus. What does that do for us? What scleral icterus does is that it tells you the patient's bilirubin is up. And that honestly wouldn't be my focus right now. And we can discuss hyperbilirubinemia, how we break it up into direct or indirect, but I don't even want to make any hypotheses as to why this patient's bilirubin is up. But what I do know in my mind is I'm going to look at those liver chemistry tests. I'm going to fractionate the bilirubin. I might have to get abdominal imaging pending that. But for me right now, I have a hypotensive individual, 10 out of 10 abdominal pain with jugular venous distension. So could they have a dissection, for example? So the other thing I want to mention, because it's come up twice for me in the past month, is elderly and those with diabetes, they have really atypical presentations of cholecystitis, meaning that they may have a little bit of pain or they may not sense the pain. And if you don't treat cholecystitis, the complication rates are very high. And those complications include gangrene, perforation, fistulas. So I would be interested with the hyperbilirubinemia, the abdominal pain, the history of diabetes, what's happening with that gallbladder and the biliary system. So where am I going next? IV fluids, you take your choice. EKG, troponin. Once I stabilize them, I'd have a very low threshold to get a CT scan. You're going to probably get an echocardiogram at some point, send the BNP. But let's get the basics labs. And if that bilirubin is really high and is out of proportion to the degree of what seems to be heart failure, then we can incorporate that into our problem representation to make progress. But right now, your only focus, hypotension, volume overload, 10 out of 10, epigastric pain. That's really should be your primary focus.
All right, excellent. Let's keep on going with the labs. So I'll start with the CBC. His white count was 18 initially and went up to 26 a few hours later. Hemoglobin's 13.2 and platelets are 160. His sodium is 132, potassium's 3.2, chloride's 102, bicarb is 21, BUN's 30, and creatinine's 1.7. AST is 170, ALT is 380, alk-phos 150, T-Billy 6.1, D-Billy 4.9. Lactic acid was 6 initially and improved to 3 after the 3 liters. His B Nancy P is 3,300, and his high sensitivity trope is 28,000 and increased to 35,000 about 2 hours later. And I do have some imaging I wanted to show you guys, an EKG and a chest x-ray, so I'll go ahead and share my screen. There's the EKG. See if I can make it. Did that make it full screen for you guys?
Yes, it does. And why don't, Aaron, are we making good as far as time? Are we going at a good pace?
Yeah, pretty good.
Okay, so why don't everyone just take 30 seconds, look at this EKG. Don't even write anything in the chat yet. Just interpret it for yourself. Imagine you are Aaron and you're looking at this EKG. So everyone interpret it. I'm going to do the same thing. Then I'll take a crack at it. And then Aaron will tell us what the official read of the EKG was. All right, everyone has had a chance to look at that. Feel free to put whatever you want in the chat. Aaron, I'll tell you, when I approach an EKG, really I'm asking myself 3 questions. And anytime I'm approaching an EKG that's abnormal, I always ask what was the prior EKG, so I have something to compare it to. It's very, very helpful. The same way we ask, like, what was the prior creatinine? What was the prior hemoglobin? And I ask myself 3 questions. Is the rate regular, fast, or slow? Is the QRS complex narrow or wide? And is it regular or irregular? Those are like the first 3 questions. I look at that rhythm strip at lead V1. And right away, I honestly don't even like count anymore. I just have a sense like it just is going a little bit fast. It's not slow. It's wide. The QRS complex is wide. And it's regular, meaning it's going at regular intervals. Once I do that and I say, okay, I have a wide QRS complex, it makes you think of a bundle branch block. So then I look at V1, and V1 has sort of this RSR prime, and the lead V1 is over that right ventricle. So it's telling you that you're probably dealing with the right bundle branch block. And then you see these deep S waves in V5 and V6, which would be consistent with that hypothesis. Then what I do is I look at the isoelectric line to see if there's any ST segment elevation or depression. And just like looking, and this is when I actually go in territory. So I'll look at the inferior leads like 2, 3 AVF, the lateral leads 1 AVL, V5, V6. And when I do that, I'm not really seeing any like striking ST segment abnormalities. In this patient with hypotension, I would also look at just the height of the QRS complex to make sure I'm not missing a pericardial effusion. And for that, if it's less than 5 in the limb leads, then you can say that there's decreased voltage, but it doesn't look less than 5, or if it's less than 10 in the anterior leads. So my read of this is I would say maybe a little fast, regular, right bundle branch block. But Aaron, tell us what your read was and the official read was of the EKG.
That was exactly what I read it at, and the cardiologist later said to right bundle band block. And yeah, no ST segment elevation, no T rate depression. So nice, fantastic. And this is just the chest X-ray from admission. I want to show you guys too.
All right, everyone, just before you write anything in the chat, because everyone should take a crack at this themselves, just take a look at this. We'll just spend 10 seconds. Look at it and interpret it. Look at it, interpret it, and think about our patient that we're caring for. Okay, so I'll take a crack at this. And once again, I don't go through the A, B, C, D. Like I'm just looking at a chest X-ray and I have a pretest idea of like what I'm looking for. Like if someone has a fever and a cough, I'm looking for a pneumonia. If someone is short of breath and I have concerns for heart failure, I'm looking for edema. What I see with this chest X-ray, one is like I mean, I wasn't there when we got the chest X-ray, but it doesn't seem like they have great inspiratory effort, which can make stuff look wider. And you can see a lot of whiteness. Like if you look at a lot of X-rays, you'll see that there's much more lucency or darkness, which represents air. So this, like throughout both lung fields, there's just a lot of like fluffy and interstitial markings. The X-ray isn't the best to tell you exactly whether this is interstitial or whether this is alveolar filling, but in this context with jugular venous distension, troponin elevation, BNP elevation, hypotension, I'm most concerned that this X-ray is representing pulmonary edema. The one other thing I'll say too is like in the perihilar regions, it just seems a little more concentrated, like the whiteness. So I'm seeing interstitial stuff, I'm seeing perihilar concentration, and I'm seeing like whiteness that shouldn't be there throughout the lung fields.
Absolutely. Diffuse, it was read as like diffuse interstitial infiltrates, concern for pulmonary edema, infectious process cannot be ruled out, as always.
Correlate clinically?
Exactly.
Okay.
And there is one more piece I gave you guys, I think, a lot of the labs, but there is one more piece that I wanted to include in this aliquot, which was that he had a limited echo, a TTE, and it showed a decreased ejection fraction to 35–40%, an akinetic mid to lateral and apical segments, and grade 1 diastolic dysfunction. So that's the end of the third aliquot here.
Sorry, in the background, there's like golf teaching videos. Let me mute that because I've been like learning golf. This is my favorite. I don't know why I'm like part of this subscription plan. All right, that was embarrassing. Okay, let's get this. All right, so this was a very rich aliquot of information. And I think most importantly, this white count, like this patient has a robust leukocytosis, and I'm assuming it's probably neutrophil predominant, but please correct me if I'm wrong, Aaron. And you're also seeing a thrombocytopenia. Of course, we don't have like the baseline. This patient hasn't been in care for several years, but there's a thrombocytopenia, there's a leukocytosis, there's an elevated temperature, and there's hypotension. So to me, this patient is an inflammatory shock. And with the thrombocytopenia, that would make me think, oh, are they also in DIC? So I would get D-dimer, fibrinogen, INR. The creatinine being elevated, usually it's not grabbing too much of my attention because like the patient's in shock. I would expect it to be elevated. So I think it's more of a bystander than something that's going to signal to the final diagnosis. But the bilirubin is interesting. So patients with heart failure can have hyperbilirubinemia, oftentimes it's indirect more so than direct, and it's not too elevated, but you can get abnormal LFTs with congestive hepatopathy. This may represent that, but it just seems a little out of proportion to what my experience is as a clinician. So it would make me just wonder, is this direct hyperbilirubinemia just because of heart failure, congestive hepatopathy, or is there some kind of intrahepatic or extrahepatic obstruction? So I would get an ultrasound of the biliary system and the liver to see if there's any biliary dilatation. But my entire focus would be for inflammatory shock. And when we have inflammation, don't make it too complicated. Just ask the question, where might that inflammation be originating from? And in this case, like, it seems everything is centered on the heart. Because if I went through this thought exercise and said, I have an inflamed heart that's leading to a reduced ejection fraction, then I can explain the jugular venous distension. Then I can explain the, did you guys see the thumbs up? Then I can explain the pulmonary edema. And then I can also explain potentially the EKG abnormality, because everything is happening to the heart. You have to temper that just a little bit and be open to the possibility that the heart can be the bystander. When can the heart be the bystander in the setting of shock? Is when you have Takotsubo, stress-induced cardiomyopathy. So could everything be originating from the hepatobiliary system through some kind of infection like cholangitis? And because the patient had 10 out of 10 abdominal pain, and actually the heart is just stress-induced cardiomyopathy causing, it is possible. So you have to sort of go down both routes. With this newly reduced EF and elevated troponin and electrocardiogram, I'm really worried about the myocardium. So like the heart, you just break it down into the myocardium, the endocardium being the valves, the pericardium, and the conduction system. Here, we have a limited echo. We'll get a formal echo, and we'll see if there's any primary valvulopathy. But no, when someone's heart is stretching out, they're going to have some regurgitation. But I don't think that's the primary pathology here, but you have to be open to that. I think it's really the myocardium. And suddenly I'm worried, could this patient have myocarditis and be in shock from myocarditis? To make progress on that, you're going to need your formal echo. You may need a coronary angiogram. And he is elderly, so you can have CAD, ACS. And you might need an MRI with gadolinium to just better evaluate the myocardium. I think at this juncture, you have to think of myocarditis. You have to, because myocarditis is not something you want to sleep on. And the clue to it is when you have inflammation and you have a center of gravity that's in the heart. So, Aaron, basically, I have like two pathways of thinking, and I'm open to either one unfolding. But a common theme for both pathways. The common theme is inflammation. The two pathways is whether everything is at the heart, specifically the myocardium, and then everything is backing up, causing abdominal pain, the hyperbilirubinemia, etc. Or is the problem within the hepatobiliary system? And now the heart is just stressed out because of the catecholamine surge. So what I would do is I would put this patient on broad spectrum antibiotics. I would get further imaging, specifically formal echo, maybe an MRI, but also ultrasound of the abdomen to see what's going on with the hepatobiliary system, get the blood cultures, keep them on antibiotics. And I know this individual is from Mexico, but the majority of people that are from somewhere outside of the US, their diagnosis has nothing to do with from where they traveled from. It happens that those cases end up always being presented. So we say, oh, it has to be this. It has to be the indoor dogs. Let's keep it authentic. I'm not incorporating Mexico just yet until I get more clarity. Is it a myocarditis or is it hepatobiliary? And before you give us the next aliquot, I would just love to know what you were thinking of. What were you and your team thinking of at this juncture?
Yeah, so I love that you divided it into those two branch points. We maybe I'll say unfortunately, but fortunately, we already had the right upper quadrant. So that's a hint that, that kind of led us to go down one path. And initially, so I was in the ICU when I admitted this patient, and initially we kind of attributed um, uh, the TTE findings to stress my cardiomyopathy, as you said, and the troponin elevation to kind of demand ischemia from sepsis. But it's actually beautiful that you bring up those branch points, but because after, which I'll get into, after he was treated for the hepatobiliary stuff, we had to kind of rewind and go back to square one and wonder, does he have underlying disease that predisposed him to all these cardiac issues he's having now, or is this truly just secondary to this severe sepsis that he had? So that was something we had to backtrack on and reevaluate. So
Thank you.
yeah. Okay, so moving on. So we did have the right upper quadrant already when by the time I saw him, it was done pretty fast. And he also had a CT abdomen pelvis. They showed biliary dilation, numerous gallstones, fat stranding around the pancreas, concerning for pancreatitis as well. So on admission day one, he actually went for an ERCP and a sphincterotomy. And he had 2 biliary stents placed. His white count and his liver enzymes actually improved over the next few days, and he was on broad spectrum antibiotics, vanc and zosyn. His blood cultures grew out E. coli, so we stopped the vanc, just kept him on zosyn. The formal echo that we obtained showed similar findings, the EF about 35%. He didn't have any valvular abnormalities, no PFO, but he did still have that kind of akinetic mid to lateral and apical segments. And even though he had his biliary procedures, he continued to be kind of hypotensive over the next 3 to 5 days. So by hospital day 5, he developed profound bradycardia with a heart rate to as low as 39, but between 39 and 44. And he continued to be hypotensive. And so he had to be initiated on a dopamine drip in addition to the levofed that he was on already. So I didn't mention when he first came in, we had to put him on about 5 to 7 of levofed, and he kept kind of decreasing day by day until about day 3 when he started to develop this bradycardia. So we had to go back up on the levofed, and then he was initiated on dopamine. So we were all pretty puzzled because we presumed it was kind of a septic shock that caused all of this, and his troponins had come down. His labs, his white count, his biliary labs had all come down, but he developed this profound bradycardia on day 5, and we were all pretty perplexed. So I wanted to open the discussion.
Yeah, this is I want to say what an interesting case so far. And like I just want to quickly like look back at the case. I'll talk about the bradycardia, but jaundice, abdominal pain, inflammation should make us all, we were talking about the life-threatening causes of abdominal pain. One of the life-threatening causes of jaundice that I always go and check through my head is cholangitis. And it's like, and I think that was a very plausible explanation to this patient's presentation with the bacteremia. And I think you're thinking about the heart now at the right time, like you don't want to jump the gun. The only reason I had to chase both is because I didn't have that CT scan or the ultrasound, for the purpose of the exercise that we're doing. And this is what's, I think, incredible about medicine is that like time may guide us in different directions. Like if someone it doesn't have the expected response, then we do have to step back. And here, when we have bradycardia, like the important thing to note is you want to know, is it sinus bradycardia? Is it a complete heart block? Is there, an abnormal and a lesion in the conduction system. And what will help you with that is you have to go back and review the telemetry. You have to get the electrocardiogram. Uh, and the bradycardia, like when it happens, is also important. Like I've been tricked in the hospital where someone's sleeping, their heart rate is 40, and I get worried when I was my younger years. But it's just them sleeping, you know. And but in this individual who, you know, has every reason to be like, think about it. He's hypotensive, he's on pressors, and he's bradycardic. That doesn't make sense, you know. So this, what that does for me, Aaron, is tell me that something is wrong with the conduction system, and I just wouldn't be able to explain that through E. coli bacteremia or cholangitis or stress-induced cardiomyopathy. So now I'm wondering, could he have like two things happening at once? And is there something infiltrating that conduction system? When you're approaching bradycardia, very low hanging fruits. Are they on a beta blocker? Is there an electrolyte abnormality, particularly potassium, magnesium, calcium? Whenever we're thinking about any kind of conduction system stuff, I use the mnemonic LIDO, lights, ischemia, drugs, and hypoxia for any kind of conduction abnormality. But I look at the meds, I think about TSH, and if those low-hanging fruits aren't present, then I go to more exotic stuff. And in an elderly, if his whole presentation was bradycardia, there is the aging of the conduction system. It's like Levs and Lergier, something like that. It's just a fancy way of saying that like as we age, everything goes south. I was gonna say everything goes to shit, but everything goes south, including the conduction system, the bone marrow, the brain, the kidney. That's why you got to exercise, sleep, do your best. Well, but it's none of that. So then I have to ask the question, I'm gonna get a TSH, and I'm worried, like, again, is there something that's infiltrating that myocardium? Other low-hanging fruits is stuff like Lyme disease. There are some tick-borne and rickettsial infections that can cause conduction system block, and you have to evaluate for those because they may negate the need for a pacemaker if the patient has complete heart block. So, Aaron, I'm getting a TSH. I am making sure that I'm not missing something as simple as Lyme disease, that this patient might be exposed to ticks. So I would be considering Lyme disease. And then on top of that, if I don't have an obvious answer, I would get probably an MRI with gadolinium, because now I'm worried, like, is something infiltrating the myocardium and the conduction system? And then that may make me think of granulomatous processes or other etiologies. But I'm just going to keep it real. I don't want to make a hypothesis just yet, but really I'm just, is it TSH? Is it Lyme? Is there, I know there's no medication. Is there something that's infiltrating that conduction system?
Awesome. Okay, so yeah, I think I wrote in the chat, but it was sinus. We did all the workup for low-hanging fruit. Of course, that was all ruled out, and he was not, getting any beta blockers or any reason. I also looked up there's a case report of somebody getting some like timolol eye drops and that causing bradycardia, and they couldn't figure it out for a long time. But he did not get any eye drops. I went back and looked.
Literally, that happened to me at the VA during my second year of residency.
Really?
I swear, and the cardiologist taught me.
That is hilarious. I just didn't think that like eye drops could, like
I
get
didn't
into
either.
crazy. But yeah, I checked and he didn't have any of that. So he actually was bradycardic for the next 3 days, and ultimately cardiology decided to put in a pacemaker. So he had to get a pacemaker placed. And then that was on day 10. I'm sorry, day 8. He was able to be weaned off dopamine after the pacemaker, but he was still requiring norepi, the levofed. On day 11, he finally was able to wean off the levofed, and then he had a left heart cath, and that showed that he had no coronary disease. And then he had a repeat TTE showing a slightly improved EF to 45 to 50%, no hypokinesis. And he was actually, after 2 days after that, discharged in pretty good shape, and he was started on metoprolol. So the reason, I guess, before I open up for final discussion, the reason why I wanted to present this case was because I think in hindsight, it's easy to think about, okay, it's like, this organ or it's the heart, being inflamed or upset because of the sepsis and all this stuff. But in the moment, just like you were doing, discussing all the causes, and trying to get to like a satisfactory final diagnosis. But actually, this was extremely unsatisfactory case for me. And I went back and I emailed the EP doctors and all the doctors that were on the case because I had actually left the rotation by the time he got the pacemaker and the left heart cath. And I was asking, why did he get so bradycardic? It's not well defined in the literature, actually, like sepsis-induced bradycardia. We all know about sepsis-induced like heart failure, acute heart failure, sepsis-induced MIs, both type 1 and type 2. But looking through the literature, it's not well characterized specifically like bradycardia as a result of sepsis. So anyway, still very unsatisfied. And I wanted to actually just see what you guys thought or if you've seen any cases like this, because to me, having to get a pacemaker for this acute event is a pretty big deal. And even though his EF did recover, he's kind of labeled as having heart failure now. And his coronary cath was clean, and he doesn't really have any other reasons for it. Of course, we have to explore the kind of more esoteric things, which he's actually going to get a cardiac MRI, and that's pending, and all these things are pending. But I think for now, I just was wanting to hear what you guys thought about kind of this unsatisfactory case that this all resulted from this acute sepsis.
Wow. I just really want to say I'm interested to what the audience thinks of that. Like this is such a great case you brought for VMR, but it's just all bread and butter. And it also highlights how many times in medicine there are unsatisfactory or unexplained outcomes. And like, how do we deal with that as clinicians? It's like we want an answer. We're working so hard to get an answer. Maybe I just will briefly reflect on that. I think what you did is pretty incredible. Like you messaging the EP people, trying to get an understanding of like why did this happen, and so I don't know. Like I haven't experienced a case of like sepsis-induced bradycardia, and maybe Ravi or Deborah, you guys can be monitoring the chat. I don't look at the chat and see if anyone has any thoughts regarding that. But my only thought is, Aaron, this is like a phenomenal case, and it was just like such a good journey that you took us on with so many teaching points. And to me, the case was very satisfactory. There's nothing unsatisfactory about this case, honestly. And yeah, and I love the fact that he got the coronary. I should have mentioned the coronary angiogram would be another low-hanging fruit for bradycardia. And I learned in a NAGEM review article in like 2021 that when people have sepsis, they're at increased risk of ACS. So like oftentimes they have demand ischemia, but they can actually have ACS. And so I think doing that coronary angiogram, where like if you have ACS, you knock out one of the AV node or one of the pacemakers, then you can have sinus bradycardia. But Ravi or Deborah, did anyone else have anything to say in the chat before we let Erin share her final thoughts and then give the mic to Shreyas?
I didn't see anything, but I agree that sepsis in itself is a stressful event. You talked about stress cardiomyopathy, sorry. And then with sepsis, you can get inflammatory mediators that are released, and one of them is called this myocardial depressant factor, which can reduce the ejection fraction or decrease the pump activity of the heart. So in turn, also, like Erin's case, cause bradycardia. So very, very interesting case. Any other input, Reza?
Oh gosh, no, I'm gonna be using that on rounds, Ravi. Myocardial depressive fact that I'm gonna sound like I know what I'm talking about. And I think my last point, Aaron, even like when we got to that aliquot with the hyperbilirubinemia, there was like a disconnect between that degree and the fact that it was direct and it all being from the heart, which made us want to seek and understand what's going on in the hepatobiliary system. But Aaron, why don't you share your final thoughts? and then pass the mic to Shreyas to go through the teaching points.
Yeah, I just wanted to share this so the EP doctor who replied to me, he gave me actually a really interesting response that I just wanted to share. He said, of course, sepsis and these pro-inflammatory cytokines that could have caused it, but he also brought up that he suspected that maybe the EGD and the scope and the ERCP that he'd gotten that had caused some level of vagal stimulation, which then in turn caused bradycardia. And I looked this up and went through several papers about this, but it was usually like peri-op. So it was within the day that they had gotten their ERCP or their endoscopy or whatever it was. And this happened like 5 days later. So to me, that wasn't like that great of an explanation, but at least, he's an expert opinion. That was his expert opinion about one contributing cause. But my takeaways, kind of like I mentioned before, I love just bread and butter cases because I just feel like there's so much that we don't know about what we treat every single day. And these kind of twists that can happen with these very common diagnoses like cholangitis and heart failure, very, very common things that we treat in the hospital, but how nuanced they can be, and how little we actually know about them. And I will say, kind of to echo Reza's point about sepsis can increase your chance of both type 1 and type 2 MIs. And it can increase your chance of getting them even after the hospitalization. So the AHA has a really great article from 2023 characterizing that pretty much sepsis increases your chance of getting hospitalized for all kinds of cardiac conditions, including arrhythmia, heart failure, and ACS, and it increases cardiovascular related and all-cause mortalities. So sepsis should be seen as almost like a comorbidity in some cases, episodes of sepsis, because it truly is like a very dramatic and very like a big event that happens. And in this gentleman, especially with his age and kind of just how long he was sick for, I think it predisposes him to have cardiac events later on. So him following up with his PCP and following up with cardiology is very important. So those are kind of my learning points from this case.
I love that. Shreyas, the mic is all yours. Our
Sure.
friend.
Thank you, Dr. Aaron, for sharing such a wonderful case. And Dr. Reza, thank you for some of the great teaching points. So we had an 84-year-old male who came in with worsening abdominal pain, and it became 10 out of 10 in severity. And so Dr. Reza taught us that when we have such severe abdominal pain, we need to really categorize them and think about some of the life-threatening causes. For example, obstruction either of a visceral organ in the form of a bowel obstruction, or even in the form of a vessel obstruction like MI or mesenteric ischemia. And the other two categories which we really need to think of is perforation and even an ectopic pregnancy in the females. And after this, we can use the quadrant approach to approach abdominal pain in different visceral organs, but we need to tread with caution because many times some of those patterns overlap. So for our gentleman, we had epigastric pain, and that prioritizes gastritis, gastroesophageal reflux disease, peptic ulcer disease with perforation. And Dr. has also taught us that some cases of abdominal pain like constipation, colitis, and even dissection are really hard to localize. As we went through the case, we noticed that the patient had shock, and one important concern with shock is it can result in end-organ ischemia. And when we're dealing with shock, it's useful to categorize shock into hypovolemic, cardiogenic, distributive, and obstructive etiologies. And the physical exam will be very crucial in trying to understand what type of shock we're dealing with. For example, if we have warm extremities and a hyperdynamic pulse, then we can think more along the lines of distributive shock, possibly arising from sepsis. If the patient has JVP elevation, we can think about obstructive versus cardiogenic etiologies. And for this patient, 10 out of 10 abdominal pain along with shock and hypotension. And the lab also showed us leukocytosis. So we're really thinking about a septic cause of inflammatory shock and possibly even DIC. And one leading hypothesis was that this patient could have ascending cholangitis because he had elevated bilirubins and he had elevated WBC. So that was one possibility. Or we were also thinking about the fact that he could also have stress-induced cardiomyopathy or demand ischemia, because he also had some features suggestive of heart failure and also elevated troponins and an elevated BNP. So at this point of the case, we are really trying to think about two different things. We were thinking, could this be an abdominal process, infectious abdominal process, which could be explaining some of the symptoms of the heart, or could it be the heart, which is ultimately causing a congestive hepatopathy? So that's where we found ourselves at. And then we later realized that this patient ultimately did have a cholangitis, and an ERCP was performed for him. And he was also started on antibiotics, which ultimately helped normalize some of the labs. But after this episode, he had episodes of bradycardia. And Dr. Reza taught us that whenever we have a bradycardia, review of the telemetry is always very useful. But this patient continued to have bradycardia, which in spite of giving him pressors, and we realized that probably could be a problem with the conduction system. And Dr. Reza also taught us that when a person is having a bradycardia, which is unexplained, we need to think whether the patient is using medications like beta blockers, whether the patient has hypothyroidism or other infiltrative diseases, and including and also Lyme's disease. Ultimately, this patient was still developed worsening bradycardia and needed a pacemaker. And we learned from Dr. Erin that it was a case of sepsis-induced bradycardia. So that's the teaching points for today.
Shreyas, that was incredible. Seriously, I really enjoyed listening.
Thank you.
The way you organize it, it makes me feel like I actually know what I'm talking about. Though if you go back and I listen to this hour, it was nothing like that. So thank you for making me sound smart, man.
Sure.
Robbie, anything to say to close the session, or are we good to go?
Oh, nothing. I thought that was you did a splendid job. So it was a great Reza episode. So thank you for your great input. And thanks, Erin.
Robbie was texting me all the answers as the case was unfolding. Take care, everyone.
Thank you.
Take care.
Bye. Take care.